All right, welcome back. Today we are jumping into one of the most dramatic, honestly, just visually wild movement disorders you'll ever see in neurology, Ballism. The name itself just sounds chaotic, so let's get right into it.
You know, sometimes the name for a condition just tells you everything, and this is one of those times. It comes from the Greek for jumping and the Latin for ballista, the ancient catapult. And I really want you to lock that image in your head, a catapult, because it is the perfect metaphor for what these violent, uncontrolled, propulsive movements look like.
Okay, so here's how we're going to break this down. First, we'll look at what this catapult actually looks like in a clinical setting. Then, we'll dive into a patient case to make it all real. After that, we'll get into the nitty-gritty of the brain's circuitry, figure out what's gone wrong. We'll talk diagnosis and treatment, and then wrap it all up with a high-yield review to make sure it all sticks. All right, Section 1, a catapult in the clinic. So what are we actually talking about when a patient presents with this? Let's paint a picture.
So the key feature here, the thing you can't miss, are these massive, involuntary flinging movements. We're not talking about a little twitch or a tremor. I mean, these are violent, powerful motions that often start right from the shoulder or the hip, the proximal muscles. That's what gives them that huge, sweeping, catapult-like arc. It can literally throw a person off balance.
Okay, so we can break it down into a few types, but I gotta tell you, you're not gonna see all of these with the same frequency. Hemiballism, where it affects one whole side of the body, that's the classic. That's what you're gonna see most of the time. Monoballism, just one limb, or biballism, both sides of the body, much, much rarer. And they usually point to a different cause.
All right, Section 2. Let's move from the textbook to the bedside. This is where it gets interesting. Let's walk through a classic case presentation.
So, picture this. You're on call, a 72-year-old man comes in. His family says he suddenly started having these wild, flinging movements of his right arm and leg. And you know he has a history of diabetes. Right there, before you even see him, what's firing off in your brain? What's on that initial differential diagnosis?
Okay, so here's the full picture. He's a 72-year-old guy, and we know he has type 2 diabetes. That's a huge clue, right? The symptoms came on suddenly, this violent, uncontrollable flinging on his right side. When you examine him, he's agitated, who wouldn't be, and these movements are non-stop, really messing with his balance. Your quick neuro exam, no obvious signs of a classic stroke, like a facial droop or anything, but we're definitely not ruling that out yet.
Okay, so now we have our patient. This is the fun part. This is where we become detectives and connect these crazy symptoms to the actual wiring inside the brain. Let's get into the clinical reasoning.
First things first, we need to make sure we're using the right term, because there are a few lookalikes. Think of chorea as, well, it's almost like a dance, right? These unpredictable little jerks that just pop up here and there. Dystonia is different. That's more like a muscle group gets locked into a sustained, twisting posture. And athetosis is that slow, writhing, almost snake-like movement. But none of them have that sheer, violent, propulsive catapult force that we're seeing in our patient. That's Ballism.
All right, so let's think neuroanatomy. This is a key question. The symptoms are on the right side of his body. So, knowing what you know about how the brain is wired, where does that tell you the problem, the lesion, is most likely located?
Right, it's almost always on the opposite or contralateral side, and we have to go deep into the brain, into the basal ganglia, to a tiny but super important structure called the subthalamic nucleus. Think of this nucleus as a major part of the brain's braking system for movement. When you damage it, it's like you've just cut the brake lines on a car. The motor system is just free to go wild, completely uninhibited, and that's what causes hemiballism.
So what are the things that can cut those brake lines? Well, as you can see here, the #1 culprit by far is a stroke, either ischemic or hemorrhagic, that hits that exact spot. But, and this is so important, you can't get tunnel vision on stroke. You have to think about other causes, especially metabolic ones. And for our patient with his history of diabetes, the one that should be lighting up like a neon sign in your head is non-ketotic hyperglycemia.
So let's walk through exactly what's happening in our guy's brain. His diabetes is out of control, leading to this state of super high blood sugar, but without ketones. This is incredibly toxic to certain brain cells. It's believed to cause this kind of localized energy crisis in the neurons of the striatum. This dysfunction then messes up the whole circuit, essentially silencing that braking signal from the subthalamic nucleus. The brake is off, and boom, you get this explosive, one-sided movement.
All right, so we've worked through the why. We've got a really strong idea of what's going on. Now for the most important part. What are we going to do about it? Let's talk about the management plan.
Okay, get your highlighters out for this one. This is a classic, high-yield pearl for your exams, but also super useful in real life. When this is caused by non-ketotic hyperglycemia, the MRI often shows a very specific finding, a bright spot, what we call hyperintensity, on the T1 weighted images, right there in the basal ganglia on the opposite side of the symptoms. That is a massive, almost pathognomonic clue.
So while we're working on fixing the root problem, these movements themselves can be exhausting and even dangerous. We need to get them under control. A great first-line choice is a second-generation antipsychotic, something like risperidone. But the key here is the dosing strategy. You have to start low and go slow. We're talking a tiny dose, like 0.25 or 0.5 milligrams, and then you gradually increase it until the symptoms are controlled. And of course, as the underlying problem gets better, you want to reassess and try to wean them off the medication.
And look, I'm going to say it again because it's that important. The primary goal is to treat the underlying cause. For our patient, that means getting his blood sugar back to normal, safely and carefully. Now, for really tough, resistant cases that don't respond, there are other options, other meds, and even advanced things like deep brain stimulation, or DBS. But that's way down the road for most patients.
Okay, we've covered a ton of ground, from the initial presentation all the way through to treatment, so let's lock it all in with a quick, high-yield clinical review. Okay, mini case number 1. A 65-year-old comes in with left-sided hemiballism. You get an MRI and it shows a stroke on the right side, in the MCA territory. This is your bread and butter. This is the absolute classic, most common cause. It just reinforces that stroke should always be at the top of your list.
Now for something a little different. Mini case number 2. A 25-year-old who you know has an autoimmune disorder like lupus develops biballism, movements on both sides. So what does this tell us? First, this isn't just a disease for older folks. And second, systemic conditions can cause it. The fact that it's on both sides suggests something more diffuse is going on, not just a single focal stroke.
All right, time for a little pop quiz. Let's see what's stuck. I'll ask 3 questions, just pause and think about the answers. Number 1, what is the single most common cause of ballism? Number 2, a lesion in which specific brain structure is the classic culprit for hemiballism? And number 3, if you had to explain the difference between ballism and chorea to a medical student, what key descriptive word would you use?
And here it is, your rapid revision summary, the whole thing in a nutshell. The movement, wild, flinging, catapult-like. The location of the problem, usually that contralateral subthalamic nucleus. The top cause, stroke. The key metabolic cause to never forget, non-ketotic hyperglycemia, and don't forget to check that MRI. First-line med for symptoms, an antipsychotic like risperidone. And the number 1 principle, always, always, always treat the underlying cause. So there you have it. The next time you see that catapult in the clinic, you're not just going to see a chaotic movement. You're going to see the brain's circuitry, the pathophysiology, the whole story. And I'll leave you with this final thought. Now that you know how to spot and break down this one incredibly dramatic disorder, how can you apply that same thinking, that same process of linking symptoms to circuits to figure out the next patient who walks in with any kind of uncontrolled movement?